Welcome back to the deep dive. Today we are shifting gears pretty significantly. Usually we take a bit of a casual stroll through a topic, but today feels different. We're not just browsing, we're prepping. I want you to imagine the lights are bright, the air conditioning is humming, and you are sitting right across from a very stern-faced examiner at Gujarat University.
That's exactly right. We are simulating a high-stakes pre-exam study session. This isn't just about learning for the sake of, curiosity. This is about survival. It's about passing the MD anesthesiology exams. We are really targeting that postgraduate student who's read the books, who's been through the wards, but now needs to synthesize it all into a cohesive, Viva-ready performance.
And we have a massive stack of sources today. I mean, we've got the heavy hitters like Miller's Anesthesia and Morgan Mikhail. We've also got the Objective Anesthesia Review, piles of old DNB question bank papers, and the long and short cases text. So our mission today is to take this mountain of information and distill it into the ultimate audio guide on chronic obstructive pulmonary disease, COPD.
And let's be absolutely clear why we're tackling COPD. In the world of anesthesia exams, this is what we call a bread and butter topic. It's fundamental. You will see it in your theory papers. You will almost certainly get a patient who smokes for your long case, and if you survive all that, it will be waiting for you in the Viva. Let me be blunt. If you can't manage COPD, you can't be an anesthetist.
Okay, so the stakes are set. I'm playing the role of let's say, the exhausted resident. I've read the chapters, but the physiology is all tangled up in my head, and frankly, I'm terrified of saying the wrong thing to the examiner.
And I'm your senior faculty. I'm here to guide you, to point out the exam traps, and most importantly, to tell you exactly what the examiner wants to hear. We're going to cover everything from the ground up: pathophysiology, clinical features, investigations, and of course, the all-important anesthetic management.
Okay, let's do it. Let's start with Part A, Introduction and Exam Framing. So if I'm in the exam hall, I draw that long question card, and it just says obstructive lung diseases. Where do I begin without just rambling?
You start with precision. That's the key. Don't jump straight into COPD as bad lungs. That's too simplistic. You need to frame the territory first. So you begin your answer with the broad category: obstructive lung diseases.
Okay, defining the landscape first, not just this specific town.
Right. And as per the standard texts and exam guides, you need to classify this landscape. The classic exam duality, the first thing you should write down, is asthma versus COPD.
And the difference isn't just as simple as one is from allergies, one is from smoking, right? That feels too basic for an MD level.
No, that's undergraduate level thinking. For your MD exam, the critical distinction, the key word, is reversibility. Asthma is characterized by airflow obstruction that is, for the most part, reversible. It comes and goes, it's triggered by inflammation, but it can be reversed. But COPD, the definition you absolutely must memorize, and this is straight from the textbooks, is a disease state characterized by airflow limitation that is not fully reversible.
Not fully reversible. That phrase, it feels like it's doing a lot of heavy lifting. It sounds very deliberate.
It is. It does. It implies that, well, we can help a bit with our bronchodilators. The underlying architecture of the lung is permanently damaged. It's broken. The airflow limitation is usually progressive, and it's associated with an abnormal inflammatory response of the lungs to, noxious particles or gases.
Which brings us neatly to the epidemiology. In the exam, do I need to be quoting precise global statistics, or is it more about the concept?
It's about acknowledging the burden. You don't need to know the prevalence in every country, but you need to state that smoking is the primary cause, accounting for maybe 85 to 90% of cases. The key for us, for anesthetists, is the surgical population. If you're working in any busy hospital, 20, maybe even 30% of your elderly patients coming for surgery will have some degree of COPD.
So it's completely unavoidable. It's not a rare disease we're preparing for.
Exactly. And that is precisely why it's an exam favorite. It's not abstract. It tests your understanding of respiratory physiology, pharmacology, and critical care all at once. You might get it as a short note on a specific concept like auto-PEEP or flow volume loops. You might get a 20-mark theory question on anesthetic management of COPD. Or, and this is the most likely, you'll get the long case: a 65-year-old chronic smoker coming for a laparotomy.
Okay, I'm framed. I think I understand the context, I know what it is, and I know why it matters. So let's move to Part B, pathophysiology. The outline here says this is absolutely essential.
It is the absolute foundation. If you don't understand the mechanics of what's broken in the lung, you will, and I'm not being dramatic, you will kill the patient on the ventilator. For the exam, you want to break the pathophysiology down into a very specific, memorable framework.
What's the framework? How should I structure my answer?
Think of it as a tetrad. 4 key components. 1, chronic airflow limitation. That's the hallmark. 2, inflammation and remodeling. 3, mucus hypersecretion. And 4, loss of elastic recoil.
Okay, let's unpack that second one. Inflammation and remodeling. I always picture just a swollen red airway, but it's more complex than that, isn't it?
It's much more.
Yeah.
This is where you can quote your reading from Miller. It's not just simple edema. The chronic irritation, usually from cigarette smoke, causes the bronchiolar smooth muscle, the BSM, to increase in both tone and bulk. It gets bigger and tighter. The actual wall of the airway gets thicker.
So the tube itself is physically narrower even before mucus comes into play.
Yes, and then the lining of that tube changes. You get something called goblet cell hyperplasia. These are the cells that produce mucus. So not only is the tube narrower and stiffer, but you're also flooding it with secretions. That covers your third point, mucus hypersecretion. That's the chronic bronchitis component of the disease.
Right. Now, number 4, loss of elastic recoil. This is the one I always struggle to explain clearly, even to myself sometimes. I get that the lung is floppy, but why does that specifically trap air?
Let's use an analogy. It's the best way to explain it in Aviva. Imagine a brand new party balloon. It has high elastic recoil. You blow it up, you let go of the opening, and snap, the air rushes out forcefully. The rubber wants to collapse back to its original state.
Right, it empties itself.
Now imagine an old, flabby balloon that's been overstretched 1,000 times. You blow it up, you let go, and the air just sort of drifts out, slowly, lazily. That is the emphysematous lung. It has lost the intrinsic driving pressure to exhale effectively.
Okay, that makes sense. But there's another factor too, right? I remember reading something about the airways themselves collapsing.
Correct. And this is a slightly more advanced concept, perfect for scoring extra marks. It's the concept of radial traction. In a healthy lung, the millions of alveoli that surround the small airways act like guy ropes on a tent. They're all pulling outwards, holding the airway open, stenting it. In emphysema, you are pathologically destroying those alveolar walls. You are, in effect, cutting the guy ropes.
So when the patient tries to exhale, the pressure from the chest pushes on these unsupported airways and they flop shut.
Exactly. That is the definition of dynamic airway collapse. The air is trapped behind a closed door, and this single fact dictates your entire anesthetic ventilation strategy. You must give the patient a long, long time to get that air out past that collapsing point.
This leads us perfectly into section 3, types of COPD. We often hear the old terms pink puffer and blue bloater. Is that terminology still used? Is it safe to use in an exam?
It is, and examiners actually love it because it represents 2 very distinct clinical phenotypes, even if most real-world patients are a mixture of the 2. Let's start with chronic bronchitis. This is defined clinically.
Clinically, meaning it's based on symptoms, not a lab test.
Yes. The strict definition is a productive cough for 3 months in each of 2 successive years. In a patient in whom other causes of chronic cough have been excluded, these are your blue bloaters.
And why blue?
Because they tend to become hypoxemic and cyanotic quite early in the disease course. Their main problem is that the tubes, the bronchi, are clogged with mucus. They have a profound VQ mismatch. They often rely on their hypoxic drive to breathe. They retain CO2, and they develop corpuscular right heart failure, which leads to peripheral edema, hence bloating.
And the other side of the coin, the emphysema group.
This is defined pathologically. It's not a symptom, it's a structural diagnosis. It is the permanent destruction of the alveolar walls and enlargement of the air spaces distal to the terminal bronchioles. These are the pink puffers.
Pink, because they managed to stay oxygenated.
For a very long time, yes. Their primary problem isn't clogged tubes, it's the loss of surface area for gas exchange and that loss of elastic recoil. They compensate by maintaining a massive respiratory drive. They hyperventilate to maintain their PaO2. They're often breathless, thin, and cachectic because they're burning so many calories just in the work of breathing. They're puffing to stay pink.
Okay, that's a very clear distinction. Let's go even deeper now into section 4, effects on lung mechanics. We've touched on resistance, but what about compliance? This feels like a classic Viva trap question.
It is a huge trap. The examiner will lean forward and ask, "Doctor, is the compliance high or low in COPD?" And there isn't one simple answer. In pure chronic bronchitis, the compliance of the lung tissue itself is often normal. The problem is purely high resistance. However, in emphysema, The static compliance is actually increased.
That always confuses me. Increased compliance sounds like a good thing. Compliant means easy, right?
Compliant means distensible.
Mm-hmm.
It's easy to blow air in. That floppy old balloon is very compliant. It expands with very little pressure. The problem isn't getting air in. It's the lack of recoil to get it out. So high static compliance in this context is deeply pathological.
Which brings us to the monster of this whole topic, auto-PEEP, or as some books call it, dynamic hyperinflation.
This is, without a doubt, the single most critical concept for the anesthetist in this entire discussion. If you understand this, you can keep the patient safe.
Okay, explain it to me like I'm in the Viva and I'm starting to panic.
Okay, take a breath. Respiration is a cycle. Inspiration, then expiration. Simple. In a patient with COPD, expiration is pathologically slow. This is due to the combination of high airway resistance and low elastic recoil. If you, the anesthetist controlling the ventilator, initiate the next breath before the patient is fully finished exhaling the previous breath, you trap a small residual volume of air.
You're stacking breaths on top of each other.
Precisely. Breath after breath after breath, that trapped volume accumulates. The patient's functional residual capacity, FRC, begins to rise. The pressure inside the alveoli at the very end of expiration is no longer zero, it becomes positive. That positive pressure is intrinsic PEEP or auto-PEEP.
And why is that so lethal? I know it causes the blood pressure to crash, but why? What is the mechanism?
You must be able to explain the hemodynamics clearly. The heart lives inside the chest, inside the thorax. Specifically, the superior and inferior vena cava are low-pressure vessels that have to pass through the thorax to return blood to the heart. If the lungs hyperinflate with trapped air, they physically expand and compress everything around them. They compress the vena cava and the heart itself, so intrathoracic pressure rises dramatically. This leads to a drop in the pressure gradient for venous return. Less blood gets back to the right ventricle, so preload drops.
An empty heart can't pump what it doesn't have.
Exactly. An empty heart means no cardiac output. And to make matters worse, at the same time, the hyperinflated lungs are squishing the tiny pulmonary capillaries, which dramatically increases pulmonary vascular resistance, or PVR. So the right ventricle is empty, and it's trying to pump against a brick wall. This is a recipe for acute right ventricular failure and cardiovascular collapse. The patient goes into PEA, pulseless electrical activity.
That is a genuinely terrifying image. Okay, we'll definitely talk about how to fix that in the management section, but that mechanism is crystal clear now. Let's move on to Part C, gas exchange and physiology.
Right, and here we need to talk about VQ mismatch. This is your section 5.
Ventilation versus perfusion, the matching of air and blood.
In COPD, the lungs architecture is destroyed and chaotic. You have some areas where there is blood flow but no air getting in. This is a shunt-like effect.
Yeah.
This is typical of a mucus plug in bronchitis. And you have other areas where there's plenty of air but no blood flow. This is dead space. This happens because emphysema destroys the capillary bed along with the alveoli.
And I see here the DNB questions source explicitly asks about the clinical importance of anatomical and physiological dead space.
Yes. Physiological dead space is essentially wasted ventilation. You're moving air in and out of a part of the lung that isn't participating in gas exchange. But here is the anesthetic relevance you absolutely must mention in your answer. Hypoxic pulmonary vasoconstriction, or HPV.
The body's own defense mechanism against this mismatch.
Correct. Normally, if a part of the lung isn't getting oxygen, the body is smart. It constricts the blood vessels going to that hypoxic area to shunt blood towards the healthy, well-ventilated parts of the lung. It tries to optimize the VQ matching. But, and this is the crucial part, our volatile anesthetic agents like isoflurane and sevoflurane are vasodilators. They inhibit HPV.
So our anesthesia is actively making the VQ mismatch worse.
It can, yes.
Yeah.
It reopened those constricted vessels, sending blood back into the poorly ventilated hypoxic areas of the lung. This increases the shunt fraction and can cause a sudden drop in the patient's oxygen saturation right after induction. You need to be aware of this and anticipate it.
Okay, that's a huge point. Now, Section 6, ABG changes. This is an exam favorite. The whole acute versus chronic thing.
The hallmark of severe advanced COPD is chronic CO2 retention. Their bodies get used to a high level of CO2. But the body doesn't just let the blood become acidic, it compensates. We call this compensated respiratory acidosis.
And how does the body compensate? What's the mechanism?
The kidneys. It's a slow but powerful process. Over days to weeks, the kidneys respond to the chronic high CO2 by retaining bicarbonate, HCO3, which is a base. This buffers the acid.
Yeah.
So when you look at an arterial blood gas report, if the PaCO2 is high, let's say 60 millimilli Hg, but the pH is in the normal range, say 7.35 to 7.4 year, it is chronic. The kidneys have done their job and the bicarbonate will be high. But if the PaCO2 is high and the pH is low, so acidotic, it is acute. This is an acute exacerbation, and the kidneys haven't had time to catch up yet.
And that is a absolutely vital distinction for determining if a patient is stable enough for an elective surgery.
Exactly. An acute uncompensated acidosis is a huge red flag. Stop. Optimize the patient. A chronic compensated acidosis is often just that patient's baseline.
And just briefly, to round out this section, section 7, the oxyhemoglobin dissociation curve, where does it go?
It shifts to the right. You need to recall the Bohr effect.
Yeah.
A state of acidosis, so high H plus ions and hypercapnia, high CO2, both cause the curve to shift to the right.
Right, equals release.
Correct. It's an adaptive mechanism. It means that for any given partial pressure of oxygen, the hemoglobin has a lower affinity for it. It gives up its oxygen more easily to the tissues that desperately need it.
Perfect. Okay, let's move to Part D, clinical features and investigations. We're at the bedside now in the pre-op clinic. What are the key things we are looking for?
The respiratory signs are obvious. The wheeze, the barrel chest, the pursed lip breathing, you'll see those from the door. But the real money, the marks, are in looking for the cardiovascular signs. You absolutely must look for signs of cor pulmonale.
Right-sided heart failure caused by the lung disease.
Yes, and the long and short cases textbook emphasizes this over and over. You have to physically examine the patient. Look for pedal edema, swelling in the ankles. Look for raised jugular venous pressure, the JVP, in the neck. Listen to the heart for a loud P2 heart sound.
Why is this a fail if I miss it? Why is it so critical?
Because the presence of cor pulmonale means the disease is advanced and the cardiovascular system is already decompensated. It drastically increases the risk of perioperative mortality. If you stand up in a long case presentation and you haven't mentioned checking the patient's ankles for edema or looking at their JDP, the examiner will stop you right there. It shows you missed a critical risk factor.
Okay, message received, section 9. Pulmonary function tests, PFTs. This is marked as absolutely essential.
Spirometry is the gold standard for diagnosis and severity assessment. You need to know the numbers cold. The key diagnostic ratio is FEV1 FVC, the forced expiratory volume in 1 second divided by the forced vital capacity. If that ratio is less than 0.7 or 70%, that confirms the presence of an obstructive defect.
And how do we grade the severity?
The severity is then graded based on the FEV1 as a percentage of the predicted value for that patient's age, sex, and height. Mild is an FEV1 greater than 80% predicted. Moderate is between 50 and 80%. Severe is between 30 and 50%. And very severe is less than 30%. You need to memorize that table. No excuses.
What about the flow volume loop? They often ask us to draw this in the exam. What should it look like?
Okay, picture a normal loop. The inspiration is a smooth semicircle, and the expiration is a straight, sharp line going down to the baseline. In COPD, the loop looks scooped out. It becomes concave, curving inwards. Why? Because as the patient tries to exhale forcefully, their unsupported airways start to collapse, that dynamic compression we talked about. This limits the flow rate, and it drops off drastically as they exhale. It looks like someone took a bite out of a sandwich.
That's a great visual. The bitten sandwich loop, I'll remember that. And section 10, other investigations. What should I look for on an ECG?
You're looking for evidence of chronic right heart strain. The classic sign is P pulmonale. This is a tall, peak P wave greater than 2.5 millimeters high, which you'll see best in the inferior leads, so 2, 3, and AVF. It signifies right atrial enlargement. You might also see right axis deviation or a right bundle branch block pattern. These are all signs of right ventricular strain.
Excellent. Let's move into Part E, preoperative assessment. We're back in the pre-op clinic. How do we properly assess the risk this patient poses?
The history is actually more important than any of the tests. The textbooks are very clear on this. You need to ask about their functional capacity. Don't just ask, are you breathless? Ask practical questions. Can you climb 2 flights of stairs without stopping to catch your breath? 100 piece. If they can do that, their metabolic equivalent, or METs, is likely greater than 4, and they are probably a reasonable risk for most surgeries. If they get breathless just walking from the waiting room to your office, they're extremely high risk.
Okay, now for section 11, the slightly controversial topic. Smoking cessation. The patient is in front of you. Their surgery is next week. They ask you, doctor, should I stop smoking today? What's the right answer?
This is a classic exam trap, and you have to explain the timeline very carefully. There are different zones of benefit and risk. Zone 1, the short term. We're talking 12 to 24 hours. Does this help? Yes, absolutely. It significantly reduces the levels of carbon monoxide in the blood. This shifts that dissociation curve back to the left, improving oxygen carrying capacity. And it also reduces the nicotine-induced tachycardia. So quitting the night before is definitely beneficial for oxygen delivery.
But then there's a period where it's actually worse, right? The so-called danger zone.
Exactly. Zone 2, roughly 2 days to 4, maybe even 6 weeks. In this window, the airways start to wake up. The cilia, which were paralyzed by the smoke, start regenerating and beating again. The volume of sputum they clear actually increases. The airways can become hyperreactive. So paradoxically, if you stop smoking just 3 or 4 days before surgery, you might actually be more prone to bronchospasm and mucus plugging than if you had just continued.
That is so counterintuitive. I can see how that would trip someone up.
It is. So the ideal, of course, is zone 3, greater than 8 weeks. That's the minimum time it takes for the immune system to start normalizing and for sputum volume and reactivity to genuinely decrease. So for the exam, your answer is, ideally, the patient should stop smoking at least 8 weeks before surgery. If that is not possible, then quitting at least 12 to 24 hours beforehand is beneficial. However, we must be very cautious in the intermediate window of a few days to a few weeks, as airway reactivity may increase.
Perfect. What about optimization? What can we actively do in that pre-op period to make them safer?
There are 4 key things. 1, bronchodilators. Make sure they are taking their prescribed inhalers correctly and consistently. Optimize their regimen. 2, steroids. If they are actively wheezing or have had a recent exacerbation, a short course of oral steroids can significantly calm down the airway inflammation. 3, physiotherapy. This is huge. Teach them how to use an incentive spirometer before the surgery so they know how to do it afterwards. Teach them how to cough effectively, the huff cough. And 4, treat any active infection. If their sputum is purulent, so green or yellow delay elective surgery if possible and give them a course of antibiotics.
And for Section 12, risk stratification, what's the bottom line?
Remember that the surgical site matters most. Upper abdominal and thoracic surgeries carry the highest risk because the incision causes pain, which leads to splinting, and they often involve cutting through respiratory muscles. A knee replacement in the same patient is a much, much safer proposition.
Okay. Part F, anesthetic management. The main event, Section 13. Choice of anesthesia. The examiner looks at you and asks, general or regional?
And you have to give a balanced answer. For any peripheral surgery limbs, lower abdomen regional anesthesia, RA, is generally the preferred choice.
Because you completely avoid putting a tube in their very reactive airway.
Precisely. No tube means no instrumentation, no reflex bronchospasm. And you avoid the need for positive pressure ventilation, or PPV, which reduces the risk of barotrauma and that dreaded auto-PEEP. However, you must add a caveat. You have to be careful with the level of the block. A high spinal or epidural, say above T10, can start to paralyze the abdominal and intercostal muscles.
And COPD patients desperately need those muscles to force the air out.
Correct. For them, expiration is an active process. If you knock out their belly muscles with a high block, they might not be able to exhale effectively or clear secretions. So the answer is regional is good, but keep the level as low as is practical for the surgery.
What about general anesthesia, GA? Sometimes it's just unavoidable. A laparoscopic cholecystectomy, for instance.
Then we have a clear plan. We move to Section 14, induction and airway management. The primary goal is a smooth, deep induction. You want to avoid any coughing, bucking, or fighting on the tube, as this drives up intrathoracic pressure and can trigger severe bronchospasm.
LMA versus ETT, which is safer?
Well, the literature suggests the laryngeal matic airway, LMA, can be beneficial. Because it sits above the vocal cords, it is a less stimulating device, so there is theoretically a lower risk of triggering bronchospasm. But you can only use it if you don't anticipate high airway pressures and if the patient isn't at high risk of aspiration. For many of these cases, you will need a cuffed endotracheal tube, ETT. And if you are going to intubate, ensure the patient is deeply anesthetized. Using intravenous or topical lidocaine can be very helpful to blunt the airway reflexes.
Okay, the patient is intubated. Section 15, intraoperative ventilation strategy. This is marked very high yield. I am standing at the ventilator. What numbers do I dial in?
You have to remember the pathophysiology we discussed, air trapping. Your entire strategy is designed to let the air out. Number 1, low respiratory rate. This is the single most effective tool you have. A rate of 8, maybe 10 breaths per minute. Slower is better. This is the best way to increase the available expiratory time. Number 2, a long IE ratio, the ratio of inspiration time to expiration time. Normal is about 1 to 2. In a COPD patient, we dial in 1 to 3, 1 to 4, or in very severe cases, even 1 to 5.
So a very quick breath in, followed by a slow breath out.
Exactly. Number 3, permissive hypercapnia. Because we are deliberately breathing slowly for the patient, their end-tidal CO2 will rise. We must accept this. As long as the arterial pH stays above a safe level, roughly 7.20 or 7.25, we tolerate a high CO2, say 60 or 70 millimilitary, in order to protect the lungs from the barotrauma of auto-PEEP.
That's a critical trade-off. A bit of acidosis is much better than a popped lung or a cardiac arrest.
Exactly. It's a lung protection strategy. And number 4, PEEP. This is a bit controversial, but generally we apply a small amount of extrinsic PEEP, maybe around 5 centimeter H2O. The theory is that this helps to splint the small airways open during expiration and prevent that dynamic collapse we talked about earlier.
Got it. Okay, section 16, drugs. Let's run through the anesthetic cart. Inhalational agents. What's the best choice?
Sevoflurane is widely considered the agent of choice. It's a potent bronchodilator, and it's non-pungent, so it's very smooth on the airway. You should definitely avoid disflurane and probably isoflurane for induction, as they are pungent and can irritate the airway, causing coughing and laryngospasm. Halothane, for the history buffs, is a fantastic bronchodilator, but it sensitizes the heart to catecholamines and can cause arrhythmias, so it's very rarely used now.
Okay. 5 induction agents.
Propofol is an excellent choice. It effectively suppresses laryngeal reflexes and provides a very smooth induction. Ketamine is a unique and very useful option, especially in an emergency. It has sympathomimetic properties. It causes a release of endogenous catecholamines, which are potent beta-2 agonists and relax bronchial smooth muscle. It's excellent for the actively wheezing or hypotensive patient.
And what about muscle relaxants? This is a common exam question.
The rule is simple. Avoid anything that releases histamine. So avoid atracurium and bivacurium. Histamine causes bronchoconstriction, which is the last thing you want. Use rocuronium, vecuronium, or cisatracurium. These are clean drugs from a histamine release perspective and are much safer.
Opioids, same principle.
Same principle. Morphine is known to cause histamine release. Avoid it if possible. Use a synthetic opioid like fentanyl or sufentanil.
And the big one, nitrous oxide, N2O.
A huge red flag in patients with emphysema. If the patient has bullae, which are large, air-filled cysts in the lung, the late nitrous oxide will diffuse into these closed air spaces faster than nitrogen can diffuse out. The bullae will expand under pressure and can rupture, causing a tension pneumothorax. So the rule is strictly no nitrous in any patient with known or suspected bullous emphysema.
Okay. Part G, postoperative and ICU care. The surgery is over, the patient is in recovery.
The danger is absolutely not over. The post-op period is fraught with risk. The main complications are hypoventilation, bronchospasm, and atelectasis, which is lung collapse, and pain control, which is section 18, is absolutely huge.
Because if it hurts to breathe, they simply won't take a deep breath.
Exactly. That's called splinting. And splinting leads to atelectasis, which creates a breeding ground for bacteria and leads to pneumonia. Thoracic epidural analgesia, TEA, is the gold standard for pain relief after major abdominal or thoracic surgery. It provides profound analgesia without the systemic respiratory depression you get from high doses of IV opioids. It allows the patient to cough, mobilize, and breathe deeply.
What about NIV, non-invasive ventilation? Things like BiPAP.
An absolute lifesaver in this patient population. If the patient is struggling after you've extubated them, don't wait. Put them on BiPAP immediately. It reduces their work of breathing, it helps blow off any residual CO2, and it stents their airways open. It very often prevents the need for reintubation.
And if they do end up in the ICU, section 19, weaning from the ventilator.
Weaning can be very difficult and prolonged. They have weak respiratory muscles and high airway resistance. We often use modes like pressure support ventilation, PSV, to help them overcome the resistance of the breathing tube. And you shouldn't be afraid to extubate them directly to NIV to provide that bridge of support.
Excellent. Okay, Part H, exam integration. Let's bring it all home for the exam. Section 20, comparison tables. Let's start with the classic, asthma versus COPD.
Okay, let's do this as a quick fire. Age of onset. Asthma is typically early, childhood. COPD is midlife, almost always over 40. Etiology: asthma is often allergic or atopic. COPD is overwhelmingly due to smoking or noxious particle exposure. Clinical course: asthma is intermittent with symptom-free periods. COPD is chronic and progressive. And the big one, reversibility. In asthma, you see a significant improvement in FEV1, more than 12% and 200 milliliters after a bronchodilator. In COPD, you see minimal or no change.
Perfect. Now for section 21, common exam questions and Viva traps. We touched on this earlier, but let's really hammer home the hypoxic drive myth. A junior colleague says, I won't give the COPD patient much oxygen because they run on a hypoxic drive and they'll stop breathing. What is your response?
My response is that this is a partial truth that is used to justify dangerous practice. Yes, it is true that in some chronic CO2 retainers, the primary stimulus to breathe is a low level of oxygen rather than a high level of CO2. But if your patient is hypoxic, with an SpO2 of 85%, you must give them oxygen. Hypoxia kills in minutes. It causes brain death and fetal arrhythmias. CO2 narcosis, on the other hand, takes hours to develop and is reversible. You always treat the more immediate threat to life. Furthermore, the main reason their CO2 rises when you give them oxygen is due to complex physiological effects like the Haldane effect and reversing HPV, which worsens VQ mismatch. It's not just the brainstem shutting down. So the safe gold standard exam answer is,
I will administer controlled oxygen, for example, via a 24 or 28% Venturi mask to maintain the SpO2 in a target range of 88 to 92%. I will monitor the patient closely for signs of rising CO2 and drowsiness, but I will never withhold oxygen from a hypoxic patient. That is the gold medal answer. I can hear the examiner nodding in approval. Okay, another trap. The sudden intraoperative crash. We discussed how auto-PEEP can cause profound hypotension. What is the immediate management algorithm, the first few steps?
number 1, instantly disconnect the breathing circuit from the endotracheal tube. This immediately releases any trapped pressure, it treats auto-PEEP, and it also rules out an equipment or ventilator failure. Number 2, start bagging the patient manually with 100% oxygen. This allows you to feel the compliance of the lungs in your hand. Are they stiff? Is it hard to bag? Number 3, listen to the chest with a stethoscope. If you hear wheezing, it's likely bronchospasm. If you hear silence on one side, you must suspect a pneumothorax. And number 4, look at your capnograph. A shark fin shape confirms obstruction. A flat line means either there's no cardiac output or you're disconnected.
Fantastic. Section 22, diagrams. What are the essential things I should be prepared to draw?
3 things. 1, the flow volume loop. You must draw the normal loop versus the obstructive scooped out loop. 2, the capnograph trace. Draw a normal square wave trace next to the shark fin trace of bronchospasm, which has that slow sloping upstroke. And 3, a basic spirogram trace just showing a reduced FEV1 and a reduced FEC.
And finally, section 23, summary exam conclusion. Give me the 60-second summary for the listener who is walking from the canteen into the exam hall right now.
All right, here's your final recap. 1, define it. It's a not fully reversible airflow limitation. 2, pathology. It's a mix of loss of recoil, which is emphysema, and mucus and inflammation, which is bronchitis. 3, key physiology. Remember air trapping and auto-PEEP, which cause hemodynamic collapse. 4, pre-op. Focus on their functional capacity history. Smoking cessation is best at more than 8 weeks or less than 24 hours. 5, induction. Ensure deep anesthesia. Avoid any histamine-releasing drugs. 6, maintenance. Sevoflurane is your friend. No nitrous oxide if there are bullae. 7, ventilation. The mantra is slow rate, long expiratory time. Your IE ratio should be 1 to 3 or 1 to 4, except permissive hypercapnia. 8, post-op. An epidural for pain control is ideal. Use early, non-invasive ventilation. And the final word, the key takeaway, safety. The examiner wants to know that you're a safe anesthetist. They want to know you understand the risks, so verbalize your safety checks. I am worried about auto-PEEP, so I will monitor the flow curve. I will watch for pneumothorax. I will be careful not to fluid overload the right heart. Acknowledging the risks is how you pass.
Expert, thank you so much. That was intense. It was thorough, but I feel like I can actually visualize the lungs and the ventilator now.
It's a complex topic, there's no doubt about it, but if you stick to the basic mechanics, the physics of flow and recoil, it all starts to make sense. Good luck to our students out there listening.
Now grab a pen, draw that flow volume loop, that bitten sandwich, and go crush that exam. This has been the Deep Dive.
Goodbye.
Wait, hold on. We're not done yet. That was the executive summary. That was the high-yield pass-level stuff. But we have a full hour to fill, and frankly, we just glossed over some really important details, the kind of details that distinguish a pass from a distinction.
You're absolutely right. We gave them the skeleton. This is a solid skeleton. But now let's put some meat on those bones. Let's circle all the way back to Part B, pathophysiology. We briefly mentioned it, but let's talk about alpha-1 antitrypsin deficiency.
Ah, the genetic cause of COPD.
Yes. Most COPD is from smoking. But if you see a young patient, say 35 or 40 years old, who has never smoked but has severe emphysema, you must suspect this. It's a deficiency of a crucial protease inhibitor. Without it, an enzyme in the lungs called elastase just runs rampant and literally eats the elastic tissue in the lung. This leads to a specific type of emphysema called panicular emphysema, which characteristically affects the lower lobes of the lungs. You can compare that to smoking-induced emphysema, which causes centriacinar emphysema and classically affects the upper lobes.
Okay, that's a brilliant distinction. So smoking equals smoke rises, so it hits the upper lobes in the center of the sinus, so centriacinar. Genetic is systemic, gravity wins, so it affects the lower lobes and the whole sinus, so panacinar.
Exactly. Dropping a pearl like that in a Viva shows you aren't just reciting the basics from a review book, it shows you've read in depth.
Okay, let's dig deeper into Part D investigations. We talked about the ECG. What about echocardiography? If my patient has signs of cor pulmonale, what specific numbers am I looking for on that echo report that will change my anesthetic plan?
An excellent question. You are looking for the estimated pulmonary artery systolic pressure, or PASP. Normal is less than 25 millimole Hg. In a patient with severe cor pulmonale, it can be 50, 60, or even higher. If that PSP starts to approach the patient's systemic blood pressure, the risk of acute right ventricular failure on induction is absolutely massive. You are also looking for the TR jet velocity from the tricuspid regurgitation and a key measurement of RV function called TAPSE, which stands for tricuspid annular plane systolic excursion.
TAPSE, that's a great keyword to use.
If the TAPSE is low, say less than 16 millimeters, it means the right ventricle is failing. It's weak. You need to be incredibly gentle with your induction agents. A standard dose of propofol might cause a complete cardiovascular collapse. In that situation, you might choose etomidate, which is famously cardiostable, or a very slow, careful titration of ketamine.
Let's revisit Part E pre-op optimization again. We mentioned giving antibiotics for an infection. Which bugs are we actually fighting? What should I prescribe?
The common community-acquired organisms are the usual suspects: Streptococcus pneumonia, Haemophilus influenza, and Moraxella catarrhalis. But, and this is another distinction level point, in a patient who has been in and out of the hospital frequently, you must have a high index of suspicion for Pseudomonas aeruginosa.
Pseudomonas.
The nasty one, the blue-green pus.
Yes. If they have risk factors for it, like recent hospital admission or previous courses of antibiotics, you need to ensure they have anti-pseudomonal coverage, something like piperacillin tazobactam or ceftazidime. And what about their nutritional status? We see these emphysematous patients who are just skin and bones. How much does that matter?
It's a huge independent predictor of poor postoperative outcome. A low serum albumin, say less than 3.0 GDL, is strongly associated with poor wound healing, respiratory muscle weakness, and an inability to wean from the ventilator. If the surgery is elective, referring them to a dietitian for a few weeks of high-protein nutritional supplements can genuinely change their outcome.
Okay, let's expand on Part F, the intraoperative ventilation strategy. We said use a low rate, but how do we decide on the exact rate? Is it just a guess? It has to come down to the idea of time constants, right?
You know, we are talking advanced respiratory physics. This is excellent, yes. The time constant, which is often abbreviated as tau, is a product of the lung's resistance multiplied by its compliance. It is the time, in seconds, taken for 63% of the lung volume to empty during a passive exhalation. You need roughly 3 to 4 time constants to empty 95 to 98% of the lung volume. In COPD, the resistance is very high, and in emphysema, the compliance is also high. So the product, tau, is huge. It's a very long time constant. It takes seconds for their lungs to empty. That is why we need to provide 4 or 5 seconds of expiratory time. And if you do the math, 60 seconds in a minute divided by, say, 1 second for inspiration plus 5 seconds for expiration, that's 6 seconds per breath. 60 divided by 6 is 10 breaths per minute. That's where the math comes from.
So it's not a random guess. It's calculated based on the patient's specific lung mechanics. Okay, and let's talk about the crisis. Intraoperative bronchospasm. We gave the initial algorithm. Disconnect, bag, listen. But let's say it is bronchospasm. The chest is tight and you can hear a wheeze. What is the pharmacological ladder? What do you give and in what order?
A great question. This is your crisis management drill. Number 1, deepen the level of anesthesia. All volatile agents are bronchodilators. Increase your sevoflurane to 2 or 3 MAC if the blood pressure allows. Or give a bolus of propofol or ketamine. Number 2, ensure you are on 100% oxygen. Number 3, give beta-2 agonists. Salbutamol puffs directly down the endotracheal tube. You can use a specific MDI connector, or in an emergency, just disconnect and spray it right down the tube. 4, add anticholinergics. Ipratropium bromide works synergistically with salbutamol. 5, intravenous magnesium sulfate, a dose of 2 grams given over 10 to 15 minutes. It's a calcium antagonist and a potent, smooth muscle relaxant. Can be highly effective. 6, 4V steroids, hydrocortisone or dexamethasone. They take hours to work, but you give them now to help with the inflammation later on. And 7, epinephrine. This is the nuclear option. You can start with small IV boluses of 10 to 20 micrograms or start a low-dose infusion.
Epinephrine, isn't that just for cardiac arrest? That sounds quite extreme.
It is the most potent bronchodilator we have. It has powerful beta-2 agonist effects. In a severe, life-threatening, silent chest scenario where no air is moving, small doses of epinephrine can be life-saving.
Okay, let's talk about a very specific surgical scenario that comes up all the time. Laparoscopic surgery in a patient with severe COPD. This feels like a double whammy of problems.
It is one of the most challenging scenarios we face. First, you have the pneumoperitoneum. The surgeon insufflates the abdomen with carbon dioxide.
Right.
This pushes the diaphragm up into the chest, splitting it, and it compresses the lung bases. This dramatically worsens atelectasis. And second, you have CO2 absorption. The CO2 from the belly is absorbed directly into the patient's bloodstream. So you have a patient who is already struggling to exhale their own CO2 because of their COPD, and now you are systemically loading them with extra CO2 from the surgery.
The end-tidal CO2 on the monitor is just going to skyrocket.
It will. And your natural instinct as a junior anesthetist is to see a high CO2 and want to increase the ventilation to blow it off, increase the rate. But you can't. If you increase the rate, you cause autopeep. If you increase the tidal volume, you get dangerously high peak airway pressures. You are trapped.
So what do you do? What's the strategy?
1. You stick to your guns on permissive hypercapnia. You let that CO2 rise, as long as the pH is safe. 2. Communication. You must speak to the surgeon. Ask them to lower the insufflation pressure. Can they operate at 12 mmHg instead of 15? 3. Positioning. You have to avoid extreme Trendelenburg, the head-down position, as that makes the diaphragmatic splinting even worse. And 4. Conversion. If you simply cannot ventilate the patient safely, you have to be brave enough to tell the surgeon that they need to convert to an open procedure for the patient's safety.
That communication point is so key for the oral exam. You have to show that you are the captain of the ship in that room.
Absolutely. The anesthetist is the guardian of the patient's physiology. You have to advocate for it.
Let's just touch on regional anesthesia one more time with a specific block. A brachial plexus block, specifically an interscalene block for shoulder surgery. Is that safe in a patient with severe COPD?
You need to be extremely careful. An interscalene block, because of where the local anesthetic spreads, almost always causes a temporary phrenic nerve palsy on the same side. This means you paralyze that hemodiaphragm. A healthy person can tolerate losing 50% of their diaphragmatic function just fine. They won't even notice. But a patient with severe COPD who is already using every accessory muscle they have to breathe, losing half their diaphragm might be the final straw that pushes them into acute respiratory failure. So the standard teaching is to strictly avoid interscalene blocks in severe COPD. You'd want to use a supraclavicular approach, though, that has a risk of pneumothorax, or an axillary approach if the surgery allows.
Fantastic. Okay, let's do a true or false rapid fire round from some of these question banks just to cement some of these concepts. Okay, number 1. Routine use of prophylactic postoperative mechanical ventilation is recommended for all patients with severe COPD.
False. The modern approach is to try and extubate them as early as possible to avoid ventilator-associated pneumonia and ventilator dependency. However, we have a very low threshold to use prophylactic non-invasive ventilation. So the strategy is extubate to NIV or BiPAP, not leave them on the ventilator.
Number 2. Inhaled salbutamol can cause hyperkalemia.
False. It causes hypokalemia. The beta-2 stimulation drives potassium into the cells. This can be clinically significant, especially if the patient is already on diuretics, which also cause potassium loss. It can trigger arrhythmias.
Okay, number 3. Aminophylline is the first-line drug for treating severe intraoperative bronchospasm.
False. It has a very narrow therapeutic index and a lot of side effects like tachycardia and seizures. It is very much a second or third line agent now. The inhaled beta agonists, volatile agents, and magnesium are all superior and safer.
Last one. Using a larger endotracheal tube, for example, a size 8.5 versus a 7.0, significantly reduces the work of breathing during weaning.
True. Absolutely true. You have to remember Poiseuille's law. Resistance is inversely proportional to the radius to the power of 4. A small increase in the tube's diameter drastically reduces the resistance to airflow. This can make a huge difference for a patient with weak respiratory muscles trying to wean.
Expert, this has been incredibly thorough. I feel like we have covered the basics, the advanced physiology, the pharmacology, and the crisis management. This is the whole package.
And we've tried to keep it exam-focused at every step. Just remember, when you're in that exam, define your terms clearly. Always explain the why, the underlying physiology. Prioritize safety above all else. And don't fall for the common traps, like the hypoxic drive myth or the smoking cessation timing.
Thank you again for this masterclass. To our listeners, you are now armed with the knowledge to walk into that exam hall, take a deep breath, a long exhalation preferably, and own the room. Review your notes, practice drawing that bitten sandwich loop, and we will see you on the next deep dive.
Good luck to all of you.